Okay, and for those who are joining us today also, just to let you know, this is the first of its kind today, so we will be sending out an email afterwards. If you have any recommendations, anything feedback-wise that you would like us to cover moving forward, just take a look out for that email. We'll be sending a survey afterwards, and anything we can do to improve this talk, also things that you'd like to see, we would really appreciate it. All right, it looks like we have some people joining us. We'll get started in about a minute. To start though, my name is Amy Hammond. I'm an RPSGT. I work with Patient Safety Inc. And today we're going to be covering SatScreen reports. So a little bit of what I'm going to go over today is primarily the 4 indicators on the front page, showing how those impact obstructive sleep apnea, also your potential courses of treatment, and who may be a good CPAP candidate versus who may be a good oral appliance candidate, things of that nature. And hopefully if we have time, get into going through several case reviews at the end. So we do have quite a bit to fit into the 20 to 30 minutes that we have set aside for today. If you do want to stay afterwards and ask any questions, by all means, I'm happy to do that. And we'll give everyone about another few seconds here, and then we'll go ahead and get started. Okay. And just to verify, if you do have any questions, we'll be reviewing those at the end of the call. If you want to add those to the chat box, anything like that, please feel free to do so during the webinar today as well. And this is our first report review. So if you do have any feedback for us too, we'll be sending out an email afterwards. Any feedback on what you would like to see discussed, what we didn't cover that you're hoping we would, or any other recommendations on how we can make this more impactful for you in the future would be greatly appreciated. So we'll go ahead and get started. So to start off, all examples that are going to be here and today are demonstrations of where the reference condition may be likely. So SatScreen is an oximetry reporting tool. So it's only meant to be used as an objective screening tool and should not be used to diagnose any disease or condition. As far as our outline for today, we're going to go over the 4 primary dashboard indicators: the RDI, or the Respiratory Disturbance Index, which is primarily used to screen for obstructive sleep apnea; the baseline saturation drift, which is used to detect hypoventilation syndrome and complex sleep disorder breathing, as well as the cycling time and cycling severity indicators. So those can give us more information about the RDI and potentially the type of obstructive sleep apnea the patient is experiencing. Some of that can, again, play into the courses of treatment and who may be a good candidate versus who may not be a good candidate for oral appliance, generally speaking. After that, we're going to go through some example cases and report reading tips. Most importantly, how to tell whether our studies were valid. And then we'll look at low risk, upper airway resistance syndrome, obstructive sleep apnea, hypoventilation syndromes. So the first and foremost thing that you see whenever you open up a SatScreen report is going to be that dashboard index on the front page. So this is meant to give you a quick snapshot of the patient's respiratory status. The first indicator there is their RDI. So in the RDI, we separate the 2 to 4% desaturations that are associated with an autonomic arousal. So essentially the minor desaturations that are disruptive from sleep, with the more major events, the greater than 4% desaturations. Now these greater than 4% desaturations are going to be similar to the AHI that they would score in a sleep lab or that you may see on a home sleep test. In the middle of that RDI index is going to be the overall RDI, or the culmination of those 2 indices. And they give you a good indication of whether or not the patient is at risk for obstructive sleep apnea, upper airway resistance syndrome, and so on. The second index is the saturation baseline drift. So what this does is this tells us the patient's overall oxygenation at rest, independent of events during the night. So this 94.9 that we see here is the highest resting baseline oxygenation, whereas this 88.6 is the patient's lowest baseline resting or stable oxygenation throughout the night. And the 6.3 over here is the difference between the two, or the baseline drift. The next two things that we're going to look at are cycling time, which is an indication of ventilatory instability and sometimes can give us some information on loop gain, and the cycling severity index, which is basically a global index to tell us how severe the patient's apnea events are. And we'll just kind of dig right into it as we're a little short on time today, but I want to leave some time at the end for questions. So first and foremost, how do we know if our study is valid? To determine your study validity, you're going to look at the duration of the recording as a first thing. So ideally with a home sleep test or an in-lab PSG, usually what they're looking for is at least 4 hours of valid recording time. So we generally recommend that for the SatScreen reports as well. In some patients, it may be hard to get 4 hours, particularly in your very young populations, as well as those who may have, especially petite women or people who have perfusion issues or low blood pressure. Sometimes it may be hard to get that 4 hours valid recording time, which is one reason why many practices will do multiple nights. Typically, you'll have at least one good night through 3 to 4 nights of data. And at least a minimum, however, is of 3 hours is needed to calculate all the statistics displayed on the report. So just keep that in mind. You may see a yellow error flag on some reports. We simply show this anytime the error on the study is greater than 10%, and it's meant to be flagged to let you know to look at the valid recording time and to also look at the raw data in the report to determine if the probe may have been incorrectly seated or there may have been some other problem with the test that warrants a repeat study. So if you see that yellow error message, it's not necessarily meaning you have to run another report. Just means that you should look at that valid recording time. Again, 4 hours is what we're looking for, and then perhaps repeat the test if necessary. And the last thing we're going to do is look at the raw data. So this is just an example of one of those error signals. And here's what we're looking for in the raw data. So this is an example of a patient where we might want to repeat that study. Anytime you see a lot of that intermittent drop off of the signal, that can indicate maybe that the probe was improperly seated on the finger, or perhaps the patient has their hand underneath a pillow, or they're laying on top of it in a way that's causing it to read inconsistently. So in a case like this, when you see a lot of this throughout the night interspersed, you may want to consider repeating the test or looking to one of your other sleep studies if you did multiple nights. These next two examples may be okay if you have 4 hours, but keep in mind a few things. So with this second example here, we have just a block where it looks like probably the probe fell off or the patient removed it for some period during the night and then put it back on and fell back asleep. As long as you have enough valid recording time to capture all of the stages of sleep, so again, 4 hours, usually you have a good enough period to indicate, to derive whether or not the patient has any issues there. Excuse me. The last example I'm going to take a look at here is something we often see when the patient is up and moving around. So you may see something where you see a lot of interspersed error signal associated with a long, slow, or pretty substantial shift in the baseline oxygenation level. Oftentimes, if you see that substantial shift and the rest of the night looks pretty normal, that's likely just the patient waking up. Maybe they're readjusting, maybe they're clenching their fist or putting it underneath a pillow. it usually is okay to use that study to perform your assessment. Just keep in mind that the baseline low and the SpO2 minimums may be impacted. All right, and we'll go ahead and jump into the cases here. So the first type we're going to look at are low apnea risks, or what would be considered fairly normal. In these reports, you're going to see a low overall RDI, so it's going to be in the green. The baseline saturation drift should be less than 6, and the lowest saturation baseline is greater than or equal to 89%. You're going to see the cycling time and cycling severity in the green, and also the autonomic events are going to be infrequent or mild in nature. Now, this doesn't necessarily rule out other sleep disorders, such as insomnia, periodic limb movement disorder, restless legs, things that can also cause a patient to be very tired or experience excessive daytime sleepiness. So if you suspect any of that going on, I would make a referral to a sleep specialist to rule out those other causes. So, and in this example here, and let me just see if I can move this out of the way so that we can see that a little better. We're looking at the RDI. The RDI shows 0 events. It's in the green. Saturation baseline drift is at normal healthy levels. It is often common for a patient to desaturate some when they drift off to sleep. Usually breathing becomes a little bit lighter, but typically that shouldn't be more than 4 to 6%. And in the cycling time and cycling severity, we also see those are in the green. And when we look to the raw data, we see relatively little activity here in the SpO2 channel, and also the pulse channel. There's a little bit of movement here towards the end, but very little pulse variability in this. Some, again, is normal, particularly in young, healthy patients with good vagal tone. They will have some pulse movement. Okay, and upper airway resistance syndrome. So this is one of the things that I get the most questions on because it's one of the hardest things to detect. So typically what upper airway resistance syndrome is, it's on the spectrum of not quite qualifying as obstructive sleep apnea, but it's still impacting the patient from a symptomatic standpoint or a quality of life standpoint. So with upper airway resistance syndrome, if you suspect that based on your clinical workup, you also want to rule out other factors that may be impacting the patient's fatigue during the day or their excessive daytime sleepiness. So you'll want to look at things like their sleep hygiene, caffeine and alcohol habits. Also, if they have a disrupted bed partner or a pet in the bed, or if they're simply just not sleeping long enough, you want to try to rule those out first before making a conclusion of the upper airway resistance. So, and in the report, again, this can look like a mild, low to mild overall RDI. Typically, your 4% DSATs are going to be less than 5 per hour, or not indicative of obstructive sleep apnea. The cycling time can be variable, so they can have quite a bit of instability in some cases, but the severity of the events or the cycling severity is going to be low. Again, you were looking for the clinical workup to be suggestive of excessive daytime sleepiness or fatigue. They may snore, and flow limitation is suspected. So as we see here in this patient, you'll note in the raw data here, you'll see some dark black horizontal lines in the raw data. Those are our cycling periods during the night. So even though they're very mild events and may not actually get scored as a RERA or greater than 4% desaturation, we do see a lot of ventilatory instability here. And we also see that instability leading to variability in the heart rate channel as well. Another type of upper airway resistance syndrome that we commonly see, especially in young, healthy patients, is where their cardiovascular system is almost fully compensating or preventing them from desaturating. So there's a few things that you can kind of look for here to give an indication of that, because typically the front page of the report will look just the same as a healthy or low risk patient. But in the raw data, you'll typically start to see, as we see some activity, even though it's very, very minute here in the SpO2 channel, you may see very drastic compensations in the heart rate. So basically the sympathetic nervous system is kicking in and at that threat of airway resistance and compensating for that or not allowing the patient to desaturate. So that's another thing to look for. So although, sometimes you may see that the front page looks relatively normal, it's important to look at the raw data for signs and symptoms like this. Okay, and here's an example of our upper airway resistance. So this patient has a lot of respiratory event-related arousals, about 9 per hour. However, they're greater than 4% DSAT is only at 2. So that's going to be similar to the AHI that they would evaluate in the sleep lab with an overall RDI of 11. So somewhere between either upper airway resistance or mild obstructive sleep apnea, if they were to get tested in a lab, would be likely here. Saturation baseline drift is in the normal range. We see a high cycling time. As we said, that sometimes that can be variable, and a low cycling severity. And again, we see that mild instability followed by compensation in the pulse channel. The next type of case we're going to look at is kind of the step up. So obstructive sleep apnea with either a low arousal threshold or mild loop gain. So these are pretty mild versions of obstructive sleep apnea, usually tend to be pretty good oral appliance candidates. And also with low arousal threshold, they've found that those patients tend to be poor long-term CPAP candidates, particularly if they're not obese. So the things we're going to look for in the report indexes here is a mild to severe RDI. We're going to look for moderate to high cycling time. So moderate to high level of instability with a low to moderate cycling severity. So a relatively high amount of instability with pretty mild events occurring. And that's exactly what we see here in this SpO2 or this raw data channel. So we see a lot of activity where one event is following another, but they're very, very mild in nature. Okay. Typically what's going on here is the respiratory control mechanism isn't working properly. So the patient is having a very brief obstruction, which causes this overcompensation where they arouse and awaken and take this big, deep compensatory breath. And that breath represses the respiratory drive, which then sends them into another obstruction. So they can get into this loop, feedback loop, where one event is triggering another. And again, as I said, there is a study by Zinchuk and colleagues, I believe it was 2018, where they found that non-obese patients with low arousal threshold were remarkably poor at adhering to CPAP long-term. So these may be the types of patients that will show up in your practice looking for an oral appliance. Okay, and here's an example of that in the dashboard. Again, we see a decent number of respiratory event-related arousals, and we see 5 greater than 4% DSAT for an overall RDI of 16. Saturation baseline drift is in the normal range, and then we have a high cycling time here and a relatively low cycling severity here. In the raw data, we see that iterated in the raw data as well. The last thing we're going to take a, second to last thing we're going to take a look at here is OSA with severe ventilatory instability or high loop gain sometimes as well. So in these patients, you don't want to pass go, you don't want to collect $200, you want to work with a sleep physician. Typically their OSA is going to be pretty severe in nature, and they may be at best usually are a difficult titration with an oral appliance. Normally research shows, mild to severe for patients are good candidates for an oral appliance. These can sometimes have a mild RDI, but sometimes their apneas can be pretty severe in nature. So it's good to at least work with a sleep physician with these patients because they're at higher risk of acute cardiovascular events and things like that. So again, what we're looking for in the report is going to be a mild to severe RDI, high cycling time, meaning a lot of ventilatory instability, and high cycling severity, meaning those events are very severe in nature. So basically what's happening here is an apnea event is occurring and they have a diminished arousal threshold where they're not waking up until it's absolutely life-saving in some instances. So like the raw data that we see here, this patient is desaturating probably into the 60% range at some point, and you'll see it pop back up very quickly at the end of the event. So they're waking up gasping for air, and as soon as they start to fall back asleep and that muscle tension decreases, they're going back into another event. A lot of times with these patients, interestingly, the pulse may not be as reactive. Sometimes that can be just because of the medications that they're on. It can also be that they're not as responsive to those obstructive sleep apnea events. And again, probably want to work with a sleep physician on this, as PAP or a combination therapy may be a first line of treatment. And here's an example that we have. In this case, the RDI is 73 overall with some mild events per hour, but 64 greater than 4% desats per hour. So pretty high there, or very severe there, actually. And the saturation baseline drift, interestingly, is still in the green range. And what that is indicating is that the patient is pretty much, if you look at their overall oxygenation, they're recovering, recovering right to that mid-90 range at the end of the event before falling into another event. And cycling time, so 73% of the night, their ventilation was unstable. The cycling severity index is kind of off the chart here, it's at 343. And the last type we're going to look at here, and then I'll open it up to questions, is hypoventilation syndrome. So with hypoventilation syndrome, this may be either overlapped with obstructive sleep apnea, or it can be independent of obstructive sleep apnea. So we'll look for anywhere from a normal to severe RDI. Usually the baseline drift or the difference is going to be greater than 6. And the low saturation baseline, importantly, is at or below 88%. So typically at or below 88%, if you're leveling off at that level, it may indicate that the patient could be a candidate for, nocturnal oxygen therapy or something of that nature. So, or at least should be evaluated for that. We see here in our saturation baseline drift index, we've got the high, which this is probably them at rest, just kind of drifting off to sleep at 96.5. And they're stabilizing down here at 81.2% once they fall asleep. So the difference between the two is 15%. So they're awake and at sleep difference is almost 15%, which is pretty drastic. It's important to know this because a patient like this, if they are scheduled for a surgery, or perhaps if they're taking any kind of sedatives, or you're thinking about prescribing a sedative or of any narcotic use, they're at very high risk of respiratory failure. And again, we're looking at here actually a normal RDI, but a very high baseline drift here, and normal cycling time and cycling severity. And we see that fall at the end of the raw data there. So that's the time that I have for this today. So I'm going to open it up to questions. And let me just take a look here. I think we had a couple hands raised. Let me see if I can. work this out here. Or if you would like to put something in the chat box, you can do that as well. Okay. And Dr. Gayola, I'm sorry if I'm saying that incorrectly. I'm going to see if you want to unmute and ask your question. Okay. I don't believe we have anything there. So with the extra 5 minutes, if you'd like to stay on, I do have some cases available as well that I can cover. Also, we'll send out an email afterwards. We want to thank you for your time today. You can use the code SSReview at checkout on sleepsat.com to save $50 off a SleepSat 3D oximeter, and we'll also throw an additional probe for free as well. So just put the 2 items in your cart, use that SSReview promo code at checkout, and you'll receive that probe free and the $50 off your purchase. So let me just go ahead and get out of here. And with the last 5 minutes here, we'll go ahead and take a look at a few case reports. I'm sorry, one moment. And this will be available for later viewing as well from Dr. Pappas. Yes, so we will send that out with the email as well. You'll have a link. And want to thank you all for your time. If you do have to take off, please feel free to do so. We'll send a copy of the recording, and again, that survey for feedback at the end. So what I'll do here is I'm just going to pull up an example of interesting example of REM-dependent sleep apnea here. So sometimes patients will have an underestimated RDI because they're only experiencing sleep apnea either in REM sleep when muscles are more relaxed, usually breathing becomes more unstable, heart rate can become more erratic. And in this case, we see the overall RDI is 6. So just on that baseline borderline of being either mild obstructive sleep apnea or upper airway resistance syndrome, we have normal saturation baseline, some ventilatory instability, but pretty mild there, and then a mild cycling severity index. And I haven't covered much of this before, but the traditional report just gives you a little bit more information about, again, the desaturations, how many they had, how much time they spent in those desaturations, their minimum SpO2. Keep in mind that the minimum SpO2 can be impacted by outliers or artifacts in some cases. And then they also give some average lows and things of that nature, but usually that's not too important to interpretation. On the second page here, you can see in the SpO2 channel, we have the desat events. Those are highlighted with orange tick marks. And then we also show the cycling with these dark horizontal black lines. So you can see in this patient, a very clear delineation. Usually in REM sleep, the patient will start going into REM every 60 to 90 minutes during the night, and those REM periods become longer and longer during the night. So you can see this patient is pretty much normal throughout the beginning of the study. Around an hour and 15 minutes in, they do start to have pretty significant desaturations here. It normalizes again for about another hour and a half, and that starts again. And then we have about a third period here that's a little bit longer than the first period throughout the night. So that gives a good indication of REM-dependent sleep apnea. And we see here that the SpO2 variability is also corresponding with some pulse rate variability here. So usually the two are related. I have quite a few reports here, hoping to get through a few more today, but let's go ahead and take a look at mild OSA case here. So we have the greater than 4% desats are 7. So that's going to be close to the AHI that you'd see in the sleep lab. We do see some minor disruptive events here, about for an hour, for a total RDI of 11. The saturation baseline is in the normal range, and the cycling time is kind of in that moderate range. The cycling severity is still relatively low. Another important thing to look at, touching on the first part of the test, is the valid recording time. So we see here that this has 6 hours and 52 minutes of valid recording time. Okay, and let me see if I can find here. We do have quite a few events here in the beginning of the night, and then some more minor cycling throughout. But this is that very characteristic sawtooth pattern that we see with obstructive sleep apnea. So when the airway becomes obstructed, the patient will start desaturating. It takes the body some time to desat to a critical threshold, or that arousal threshold. And as soon as they reach that, they're usually waking up gasping for breath very quickly. And that's why you see that quick increase in oxygenation at the end of an event. So that's pretty characteristic of a genuine sleep apnea event. So now if we want to look at that on a more severe scale, here we go. We have a little bit more updated report. We're looking at valid recording time of 7 hours and 54 minutes. The overall RDI is pretty mild in this situation. So 6 per hour of the greater than 4% desats. We have 6 minor events that are disruptive to sleep. And then we look at saturation baseline, that's still in the green range here. High cycling time and a moderate, relatively high cycling severity as well. So ventilatory instability and relatively severe in nature. So what we're going to expect to see in the raw data is probably frequent events, and most of them being pretty substantial desaturations. As we look at the traditional report, they had a total of 58 events during the whole night, rather. They spent about an hour of the study time in an OD4 event, or oxygen desaturation greater than 4% event. Minimum SpO2 recorded was 81. And moving on to the second page, we now have pulse rate data as well. So this shows that there were quite a few autonomic arousals during the night, meaning a lot of sleep fragmentation. Otherwise, the pulse rate ranges were a little low in some cases. I believe this was an athlete, so we weren't really as concerned about that minimum being at 37, as in some other cases. But the one thing that I would like to touch base on, if you're still here, is the risk factors for post-operative events and the hospitalization. So I do get some questions on those. Typically, those are more for our groups that are using this in the hospital setting. So they're just to indicate whether or not the patient is at risk undergoing surgery, or if they've had some heart failure, hospitalization due to heart failure, if they're more at risk for complications. In your circumstances, if you're in a dental practice or in a private primary care practice, probably not as important. I would just disregard those. So with the SpO2, we see our desat events. We do see them clustered here in the cycling periods, mostly. Okay. At the bottom, we do have the SpO2 and pulse graphs. So this shows the percentage of the total time and the number of events that were noted in each either SpO2 range or in a pulse range. So for example, 98% of the night here and 35 of the events were in the 90 to 100% saturation range. He had 23 events that dipped down into the 80 to 90% oxygen saturation range. And most of the autonomic events peaked in the 50 to 59 range here. We can see by that 30 value right there. Under the, excuse me, under the SpO2 channel, we do see that kind of textbook desaturation sawtooth pattern that we discussed periods before. We do see that it's pretty severe in nature. Anytime the patient is falling at or below 88%, they usually are at a higher risk of an acute cardiovascular event. So you definitely want to try to have your patient's oxygen levels at least above 88%, ideally above 90% during the night when you're doing a titration. And we do see some heart rate activity, but it's pretty mild in nature and usually in conjunction with those desaturations. All right, and I'll go ahead and leave it at that. I want to thank you again so much for your time today. If anybody has any questions and they'd like to or would like to look at a specific case or kind of case, I'll open up the floor again. Otherwise, we'll go ahead and wrap it up. Okay, it looks like we may have a question here. All right. Okay, well, thank you so much for your time. I do have one question from Dr. Nicole. What is done for hypoventilation with high drift? So that's a great question. If you're in, typically what I would recommend is a referral to a pulmonologist or a sleep specialist in that case, just to confirm that for one, as they may end up recommending nocturnal oxygen therapy for that patient if it's indicated. If you see that on one night, I will say, and the rest of the nights you do look relatively normal, do look for signs of error. Again, that substantial, very quick baseline shift, anything like that. Sometimes that can be impacted by error or when the patient is up and moving around. So I would look at that first, but if you do see that consistently, particularly if you have 2 or 3 nights that are showing a very high baseline drift, then you may want to refer them off to a physician, a pulmonologist, or a sleep specialist for further evaluation. You're welcome. All right. All right. Well, thank you again. We appreciate your time today. And if you come up with any follow-up questions at the end, we will send out a copy of the recording to everyone. If there's anything that we can do to improve this in the future, anything that you would like to see us cover, or maybe take a little bit more time on, please let me know. And any other feedback would be appreciated as well. But thank you so much. Have a wonderful day.